neuroplasticity is the brain's remarkable capacity to reorganize itself by forming, modifying, and strengthening neural connections in response to both internal experiences and also external stimuli. Historically viewed as largely confined to early development, but it is now recognized as a lifelong process supporting a range of essential functions, including learning, memory, and adaptation. There are several types of neuroplasticity, which is synaptic plasticity, neurogenesis, structural plasticity, and also functional reorganization. So this is the content that we will be explaining. Without further ado, let's get started.
Neuroplasticity allows the brain to change its structure and function in response to the environment, thoughts, and actions. The three possible mechanisms of neuronal change are chemical changes, structural changes, and functional changes. Neurons communicate via synapses using chemical messages called neurotransmitters. Short-term changes occur when neurons temporarily enhance their connection through the following methods. First, releasing more neurotransmitters into the synapse. Then, activating new receptors or modifying existing ones to strengthen the signal. Next, activate the NMDA receptor. It is a specific type of receptor. The NMDA receptor acts as a gatekeeper that responds to strong inputs. When triggered, it activates machinery that inserts more AMPA receptors into the synapse, making the connection stronger. This process is considered the core mechanism of short-term memory. Next, structural changes. Long-term memory and learning require physical structural alterations to the brain's wirings. These changes include: first, synaptic growth, the growth of new dendritic spine and the formation of entirely new synaptic connections. Second, neurogenesis. Contrary to old beliefs that the brain was hardwired, we now know that the brain can produce thousands of new neurons every day, a process that can be doubled or tripled through physical exercise. Next, cortical real estate. Frequently used areas of the brain can physically enlarge, while rarely used areas may shrink. This is driven by competitive plasticity, while different neural networks compete for cortical real estate. Next, genetic alteration. Significant mental activities such as intense imagination can get under the skin of our DNA, turning certain genes on or off to alter the physical structure of neurons. Next, functional changes. Functional plasticity occurs when neurons adopt neurons or change how they behave. First, adopting new functions. When specific brain areas are damaged, such as after a stroke, healthy tissues can be trained to take over the functions of the damaged regions. For example, the brain can rewire itself to process balance through the sense of touch on the tongue when the vestibular system is disjointed. Second, neurotransmitter switching. Stimuli like stress or exercise can cause neurons to switch from one neurotransmitter to another, such as converting an excitatory neuron into an inhibitory one. Third, cortical remapping. Sensory signals may spill over into neighboring regions. For example, in phantom limb sensation, sensory inputs from the face may project to the inactive brain region previously associated with the lost arm, tricking the brain into feeling sensation in the absent limb. These mechanisms are governed by the principle that neurons that fire together wire together, meaning that the intensity and the recurrence of signal determine how the brain's networks are reshaped.
Neuroplasticity shows that the brain can reorganize after injury or chronic pain. With repeated task-specific practice and proper sensory input, new neural pathways form and function improves. Without correct guidance, maladaptive plasticity can occur, leading to persistent pain or dysfunction. Therefore, targeted rehabilitation is essential for recovery.
Continuing our look at neuroplasticity, we move from rest to action. First, we have general physical activity. These include aerobic exercise like swimming, cycling, and jogging. These activities are powerful because they promote neurogenesis and synaptogenesis, the creation of new neuron and connection. This process leads to increase in hippocampal volume, which directly enhance your memory and executive function. Second, we look at the proprioceptive neuromuscular facilitation, or PNF. This involves specific diagonal movement known as D1 and D2 flexion and extension. This diagonal pattern activates multiple joints and muscles simultaneously, requiring the motor cortex to work harder to coordinate complex movement. Through repeated practice, this stimulates synaptic plasticity and refine motor control. Now, we transition into therapeutic intervention used to rehabilitate the brain after injury. First, on the top is the constraint-induced movement therapy, or CIM. The concept here is simple but powerful. We constrain the patient unaffected limb to force them to use the affected one. This is designed to overcome learned non-use. By forcing the patient to repeatedly practice with the weaker limb, we trigger cortical reorganization. We are essentially forcing the brain to rewire itself to activate those dormant motor pathways and restore function. Second, we have the functional electrical stimulation, or FEST. This is critical for patients with spinal cord injury, stroke, or cerebral palsy. During functional exercise like standing or walking, we use electrical impulse to stimulate major muscle groups such as quadriceps. This mimics voluntary muscle contraction, reinforcing the neural pathway responsible for the movement. So, how do we actively enhance neuroplasticity? Our brain's incredible ability to reorganize and form new connections. First, let's look at sleep and rest. It is a myth that sleep is just downtime. It is actually when your brain is most active in repair. By maintaining a regular sleep schedule and utilizing short 20 to 30 minute power nap, you trigger memory consolidation. This is essential for repairing the brain and enhancing your overall cognitive function. Secondly, we have meditation. This goes beyond simple relaxation. Meditation significantly reduces the impact of stressor, which allows for better emotional regulation. More importantly, it promotes actual neural growth, increasing gray matter density in the region of the brain responsible for attention and focus.
So for our first situation, we got the phantom limb pain. So this case is a 35 years old patient, 4 months after a right below knee amputation, presenting with phantom limb pain and sensations that the missing limb foot is still present. Strength in the residual limb is normal, but balance and body perception are disturbed. Neuroplastically, after amputation, the motor and sensory cortical areas for the missing limb lose normal input. Nearby brains regions take over this area, causing a maladaptive cortical reorganization. This creates a mismatch between motor intention and sensory feedback, leading to phantom limb pain. Neuroplasticity therefore explains both the persistence of phantom sensations and the basis for rehabilitation.
For treatment, it is important to consider the patient's specific goals along with the 10 principles of neuroplasticity to design a rehabilitation program that effectively promotes adaptive brain reorganization. Treatment for phantom limb pain focuses on normalizing the brain's re-representation of the missing limb through neuroplasticity. Mirror therapy is used by placing a mirror so the patient sees the reflection of the intact leg moving. This provides visual feedback that the missing limb is moving normally, restoring congruence between motor intention and sensory input. This helps reverse maladaptive cortical reorganization and reduces phantom pain. Graded motor imagery is applied next, starting with left to right limb recognition, progressing to imagine movements, and then mirror therapy. This gradually retrains the brain's movement prediction and reduces pain-related fear responses. Residual limb muscle activation is also encouraged. Contracting stump muscles or using prosthetic control tasks reactivates the motor cortex area of the missing limb, strengthening remaining motor pathways. With daily repetition and consistent practice, adaptive cortical plasticity occurs, leading to reduced phantom limb pain and improved prosthetic use. General exercises provide repeated sensory and motor input that promotes adaptive neuroplasticity, normalizes brain-limb representation, and reduces phantom limb pain.
For the next situation, we got stroke. So this case is a 58 years old patient, 3 weeks after a left MCA ischemic stroke, presenting with right-sided hemiplegia, spasticity, poor balance, and impaired hand function. Examination shows reduced muscle power, increased tone, exaggerated reflex, and impaired proprioception on the affected side. From a neuroplastic perspective, the stroke damaged the motor cortex, disrupting normal motor signals. However, the brain can reorganize. Adjacent cortical areas and the opposite hemisphere begin to compensate. With repeated activation, new neural pathways and synaptic connections form. This functional plasticity provides the foundation for recovery after stroke.
This is our patient's goals. Now let's move on to treatment. Treatment for the stroke patient is based on task-specific training to promote neuroplastic recovery. Functional activities such as reaching, grasping, sit to stand, etc. are practiced repeatedly. This repeated activation stimulates motor cortical areas and strengthens new synaptic connections, improving voluntary movement. Constraint-induced movement therapy is also used, as mentioned before. Mirror therapy is also applied to see the patient's reflection of the normal limb, as already discussed before. Sensory re-education through weight-bearing, joint compression, and tactile input is included to improve sensory motor integration. High repetition and daily practice similarly drive synaptic and functional plasticity, supporting recovery for movement and independence. Constraint-induced movement therapy is also used, as mentioned before. Mirror therapy is also applied to see the patient's reflection of the normal limb, as already discussed before. Sensory re-education through weight-bearing, joint compression, and tactile input is included to improve sensory motor integration. High repetition and daily practice similarly drive synaptic and functional plasticity, supporting recovery for movement and independence. General exercises provide repeated sensory and motor input that promotes adaptive neuroplasticity, normalizes brain-limb representation, and reduces phantom limb pain.
So for the third situation, we got the traumatic neck pain. So this case is a 32 years old patient with chronic neck pain 4 months after a road traffic accident, presenting with neck stiffness, dizziness, and fear of movement. Assessment reveals reduced cervical range of motion, impact joint position sense, and weak deep neck flexors. So neuroplastically, trauma affects sensory input from cervical muscles and joints, leading to distorted cortical representation of the neck and overactivation of pain networks. So the brain associates neck movement with threat, causing poor motor control and persistent pain. So this maladaptive sensory motor plasticity explains the chronic nature of traumatic neck pain.
Treatment for traumatic neck pain aims to restore normal sensory motor control and reduce pain through neuroplastic changes. Cervical joint position sense training corrects faulty sensory input to the brain and restores normal cortical representation of the neck. Deep neck flexor motor control exercises are used to improve activation of stabilizing muscles. This enhances cortical control of neck movement and reduces overactivity of superficial muscles. Visual vestibular head tracking exercises are induced to reintegrate eye, head, and neck coordination, reducing dizziness and movement fear. Graded exposure to neck movement is applied to reduce fear-avoidant behavior and retrain the brain to perceive movement as safe. With consistent repetition, sensory motor and cortical plasticity normalize, leading to reduced pain and restored functional neck movement. General exercises provide repeated sensory and motor input that promotes adaptive neuroplasticity, normalizes brain-limb representation, and reduces phantom limb pain.